Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel Never Riley. Welcome, YouTube. Yeah. We are beginning the 16th chapter today. So happy Wednesday. It's been a beautiful, so productive day. And I wish the best for all of you as well. Wish that you're ready to receive this 16th chapter. Here we go. Page 261. Maintenance of artificial airways and extubation. A most common controversial subject in the maintenance of airways is the question of endotracheal tube versus tracheostomy. There must be several general statements made prior to a discussion of this question. First, it has been thoroughly documented that patients can be maintained with endotracheal tubes for prolonged periods without serious complication. The question is not whether prolonged endotracheal intubation is feasible, but whether it is desirable and of less hazard than tracheostomy. Secondly, a tracheostomy should be avoided when feasible. Even the most enthusiastic of tracheostomy supporters preface their remarks by stating that an unnecessary tracheostomy should never be performed. Thus, we can conclude that short-term airway management up to 3 days is best accomplished via nasotracheal or orotracheal intubation. Long-term airway management greater than 7 to 10 days is best accomplished via tracheostomy. Peace, highest heart, love. What's going on, YouTube? Oh, man. It's a beautiful day. Highest heart, love. Happy Wednesday. Thank you for reading with us. All right, we're in the middle of page 261, just starting out with chapter 16. Peaceful place on YouTube where we read books and learn from masters. So thank you so much. Medical information for the people for free. Endotracheal tube versus tracheostomy. The real debate centers around the gray area of from 3 to 10 days. What should the criteria be for making the judgment of whether or not the tracheostomy would be the most beneficial airway for the patient? This must be a physician's judgment made separately in each circumstance. A great deal of variation in judgment will take place from patient to patient, physician to physician, and institution to institution. There are no universally accepted criteria concerning the appropriateness of endotracheal versus tracheostomy airway management. An important criterion for ending endotracheal intubation and performing a tracheostomy would be, for those taking notes and in the playlist, reading along, how long can the larynx be intubated before there is a significant incidence of laryngeal trauma? Laryngeal granulomas have been found after 20 minutes of intubation. Countless patients have been intubated for as long as 6 weeks without occurrence of a laryngeal granuloma. However, Some investigators have shown a direct correlation between the severity of laryngeal and tra- tracheal lesions and the duration of intubation. They have suggested that maximal permissible times for safe laryngeal intubation in adults ranges anywhere from 8 hours to 1 week, in children anywhere from 2 days to 3 weeks. The authors believe that the maximum safe permissible time of endotracheal intubation should be that time at which the incidence of sequelae increases significantly in that institution. In our hands, most sequelae of glottic origin in adults occur after 3 days of endotracheal intubation. Tracheostomy is always performed by an experienced surgeon at an elective time. The patient always has an endotracheal tube in place. In our experience of over 700 tracheostomies done under these conditions, the complication rate is less than 2%, infection accounting for most of the complications. For any institution applying these modern respiratory care principles, the following guideline is safe and clinically applicable. Peace, YouTube. What's going on? Thank you for the likes and subs. We're pushing towards 1,000 subs on this peaceful part of YouTube where we read books and learn from masters. All right, so we're in the middle of page 262. Here we go. If there is a reasonable chance for the patient not to need an artificial airway in 72 hours or less, leave the endotracheal tube in place. This same evaluation is made every 24 hours. As long as it is our judgment that the patient may not need the airway in 72 hours, we will continue with the endotracheal tube. If it becomes our judgment that the patient will definitely need the airway for more than 72 hours, we will recommend a tracheostomy. We base this on our experience that when the judgment is made that the airway will be needed for more than 3 days, it usually is needed for significantly longer. That's powerful. That's powerful. It should be emphasized that this guideline is in terms of adults only. Yeah. The question of tracheostomy in small children and infants is a much more difficult problem. It is the author's opinion that the decision for tracheostomy in infants and small children must be made almost entirely on the availability of pediatric surgeons with significant expertise. If such surgeons are not available, tracheostomy should be avoided if at all possible. And we know that now, right? That's, clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition, Yearbook Medical Publishers, Inc., 1979. So now we've progressed, but the basics are still the basics, right? So it's always important to what I like to call reestablish or reinforce information of self-healing and knowledge. Thank you so much, Solar. Hi, it's Heart Love. Thank you for being here and reading with us. Yeah, live from the light here in LA. Man, it was a beautiful day. We had a wonderful meditation with Lorianne Speed, as your normal Wednesday, as you'll see in the channel and the playlist. Wednesdays are the grocery giveaway here in LA. And it was beautiful, beautiful, wonderful. then I had to go into the studio and do some work. So that's why I'm coming to you a little bit later on Wednesdays, unless I get you in the early AM. So, hi, it's Heart Love. Thank you for reading with us. It should be emphasized that this guideline is in terms of adults only. The question of tracheostomy, yeah, in small children and infants is a much more difficult problem. All right. Contamination of the airway. At the bottom of page 262, no bacteria exists below the level of the larynx in normal woman or man. Ding! I'll read it again. No bacteria exists below the level of the larynx in normal woman or man. This is not true of the upper airway where there is normal flora. The existence of bacteria in any area where they do not normally exist is known as contamination. Contamination does not necessarily mean there is an infection in that tissue. Infection is defined as a tissue inflammation in response to an invasive organism. Bacterial infection is usually accompanied by numerous white blood cells that have come to the area to attempt to ingest the phagocytides. Yeah, the phagocytize the bacteria. This accumulation of white blood cells is called pus, and the process is termed purulence. Presence of bacterial contamination in the lower airway is not synonymous with the presence of clinical infection. A culture of bacterial organisms from the lower airway does not mean that a pulmonary infection is present. Top of page 263. Diagnosis of pulmonary infection. How does one diagnose the presence of a pulmonary infection in the lower airway? Infection in the lower airway is diagnosed clinically by one, the presence of white blood cells in the sputum and the presence of intracellular bacteria. Two, fever, raising the temperature, right? Three, an increase in white blood count, leukud, yes, leukocytosis. And four, X-ray and auscultatory evidence of new or progressive pulmonary infiltration. A combination of these factors must be present in order to make the clinical diagnosis of a pulmonary infection. And we know auscultation is when we're feeling for it and listening, right? Okay. Here we go. Purulent tracheobronchial secretions. Peace, Ronnie. Peace, Chris Fly, Chris Lee. Oh, and Pax, Sulfur. Oh my goodness. Hi, it's Heart Love. Thank you so much for being here and reading with us. If you're a part of the book lovers community, that's why probably you came to this channel. We've been featured a couple times on YouTube now. And so thank you so much for reading live from the light. See, the difference with the lives as well is there's no commercials. So you get to just read with us. But they'll be in the playlist as well. So hi, it's Heart Love. Reading medical books this time around, man, it's so big. I know it's a lot of big words and vocabulary. I will put it in the um, In the list, in the playlist, it will be in the description, the vocabulary. Thank you so much. All right. The diagnosis of pulmonary infection. How does one diagnose the presence of a pulmonary infection in the lower airway? Infection in the lower airway is diagnosed clinically by one, the presence of white blood cells in the sputum and presence of intracellular bacteria. That's what I just read, but I want to read it again for the people here live. 2. Fever. 3. An increase in white blood count or leukocytosis. And 4. X-ray and auscultatory, auscultatory evidence of new or progressive pulmonary infiltration. A combination of these factors must be present in order to make the clinical diagnosis of a pulmonary infection. Purulent tracheobronchial secretions. A sample of sputum must be obtained when pulmonary infection is suspected. Under the microscope, purulent secretions will be seen as numerous white blood cells. That's right. That's why it comes out looking white, right? There may be numerous bacteria present in the sputum smear from the upper airway. This normal flora is not inside the white blood cells. The presence of intracellular bacteria denotes the fact that the white blood cells have been ingesting the bacteria in the airway. Sputum cultures will grow bacterial colonies after several days of incubation. This will allow for identification of organisms and their particular sensitivities to antibiotics. Most sputum cultures will grow oral flora. Sometimes it is desirable to obtain a direct tracheal sample. This is accomplished by TLA, or translaryngeal aspiration, which is done through the cricothyroid membrane. The respiratory care practitioner must be familiar with the examination of sputum smears under the microscope since these are immediately available, whereas cultures take several days to incubate. Fever. Most pulmonary infections will be accompanied by increases in body temperature, a general body defense mechanism in response to infection. Pathogenic bacteria do not multiply well in temperatures above 37 degrees Celsius. Thus, an increased body temperature is a helpful defense mechanism. Although pulmonary infection can be present without fever, this would be the exception rather than the rule. Increased white blood cell count. The usual response to an infection, and especially to a pulmonary infection, is to mobilize increased numbers of white blood cells from the bone marrow and other storage areas. These white blood cells are used to phagocytize the invading bacteria. An increase in the white cell count of blood is a helpful corollary to the diagnosis of pulmonary infection. Clinical examination of the chest. Clinical examination of the chest will often reveal the presence of rales, rhonchi, or bronchial breath sounds when a pulmonary infection is present. Although these are helpful clinical findings, it must be emphasized that they may be absent when there is significant pulmonary infection. Chest x ray. Chest x ray may be extremely helpful in the diagnosis of pulmonary infection. The existence of new or Progressive pulmonary infiltrates on the chest x-ray is excellent evidence of the existence of pulmonary infection. It is essential to remember that the presence of bacteria within the lower airway does not mean there is infection present. Pulmonary infection is a clinical diagnosis and must be made on that basis. It is a serious error to confuse contamination of the airway with infection of the airway. We'll pause right here. Continue back in the middle of page 264 of clinical application of respiratory care. I'm your moderator and narrator, Uriel Navarre Riley. Thank you so much. Wow. We made it to chapter 16. Oh my goodness. This is so awesome. All right. Chapter 16 on this 44th edition of reading. So thank you so much. Oh man. Love you. I love you. I love you. I love you. I want to drink some love water and show one another some love. Reading with us, shaking it up on YouTube, right? Hey 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 hey. We did it! We entered chapter 16. Doing it. We are doing it. Live from the light here in LA, where the masters are going to be mastered, right? That's what we come here for. The healing, the love water, the saying I love you, the reverence. Yeah, it's the real deal, right? I love you. So cheers to all September birthdays that we are celebrating, right? We love you so much. That Virgo energy is so strong. We're moving on. Mm. I love you. I love you. I love you. Highest heart. We did it, right, Silver? Oh my goodness. My birthday is. Yes! Happy solar return. Happy solar return. Thank you so much, man. Live from the light, man. The light workers, we're here. We're here for you. So, I want to sing I love you to Sofa as well. And to all our friends and family. You know, we love you so much. We really do. Yeah. You are the truth. Hi, so I love. Let's see the loves and heart flutters. Hi, it's heart love. So, to Sofa, September 19th, and moving on where we are now. All the wonderful birthdays, light workers, we love you. Thank you so much for reading books and healing ourselves. We can help heal others around us, right? This is the peaceful part of YouTube. This is why we do this. I love you. I love you. You know, because I love myself, the light heart. We keep our light heart, right? And to do that, we have to release so that we can receive. So I'm so grateful and thankful for all I have now and all that is coming to me. I'm ready to receive. I believe. Highest heart love. We're doing it. Thank you so much for the love. Peace, peace. I'll see you soon. We're moving towards 600, and then we'll go get to 1,000. Reading books. I mean, it's all reading books on this channel. So thank you for enjoying the piece with us. I love your energy too. Hi, it's heart love. Peace, peace. Enjoy. Have a wonderful evening and rest. We are going to, oh, yes, I had to tell you. We're going to the lavender cloud tonight. Lavender cloud. Peace, peace. I'll see you there. Healing the people. Peace.